Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much, Dr. Afa, for your beautiful presentation. I liked where you have presented it in terms of classification of prostheses, what are the type of prostheses present, and then you discussed the current procedures and as well some of the advancements. The advancements you have placed were in terms of review articles, advanced review articles, and I thank you very much for your effort. The classification of or the outlay of the presentation was very beautiful. Thank you very much. Okay, you also did in the first part where you have talked about how to reduce the incidence of these malfunctions. And it was very clear in the removable partial dentures. I wished I could see more of this slide, how to prevent these types of failures. Okay. For example, you have talked about you have classified patient-related factors, the dentist-related factors, technician-related factors. So you have presented them very well. But I wish I'd seen those also for the non-removable. Okay. So how to, not only the repair, but also the prevention. Okay, so those were beautiful. Then you talked about the chipping and the types of ceramics present and how to do them. I love this schedule where we can talk about the removal of some, or let's say repair. So you talked about the repair intraorally, but you haven't talked about where are the cases that we need to remove. Okay, so for here, I want to first, before when we talk about ceramics, there is something called catastrophic failure, and something called repairable failure. Okay, repairable, that means that we can repair it inside the patient's mouth. Catastrophic, it means it needs either the replacement of the prosthesis or removal even of the abutment tooth. Okay, so it's called catastrophic. So you need to classify this. So these repairs, you need to classify them first as catastrophic failures and as repairable failures or restorable, repairable, or you would find these types of work in the literature. There are also, in terms of the papers themselves, I find that you've chosen some review papers, but the review articles or the work when we talk about the prognosis of the prosthesis, you have put in numbers of such failures. So that is also beautiful when you put the prevalence of each failure in terms of the restoration. But that prognosis comes from types of review articles where they talk about, they review the service of these types of restoration. So it could be either lifetime of this restoration. It could be called prognosis of this restoration. It could be talked serviceability of the restoration, and so on. So it talks about the long-term success as well. So we're talking about different names used in these review articles. They are retrospective, meaning looking at numbers for previous treatments. So they called retrospective studies. And as well, they're sometimes called life expectancy, life limits, and so on. So you have multiple names for these articles, and they also have different recall periods. So it's preferable for these recall periods. They are sometimes 5 years, they are sometimes 10 years, and they're sometimes 15 years. Usually the 15 years survival rate or the serviceability for 15 years or retrospective studies for 15 years of service, these come usually for the old treatments and those that we were using before. But usually when we have new material, for example, monolithic material, you might find 5 years survival rate, you might find 10 years survival rate. But monolithic is actually somewhat a new concept, for example, monolithic ceramics. So it's important to understand what are the types of studies we look for when we are looking about the long-term service of the restorations. So first of all, the classification of the repairs. Secondly is the type of the paper. It's preferred that we use review articles or retrospective studies of survival rates that are more than 5 years. So we will accept 10 and 15 years, usually for prosthetic procedures, okay? Also, when you talked about, then after that, So I would like to see those studies for the ceramic restorations. Inlays and onlays, you talked about them shortly, but once more, you haven't talked about more about these retrospective studies and the prediction, okay? The prediction means from the pool of studies, we can predict how much failures will happen. So these are another type of studies. Once more, in those studies, you didn't talk about how to diagnose, for example, fracture of dentine, or let's say fracture lines in tooth structure. So it's not only that the restoration or the prosthesis fails, also the tooth fails. So you need to go into how to diagnose fracture lines and fracture of tooth structure, especially unseen fracture lines. Okay. So what are the signs of a dental fracture beneath those prostheses? Either if it's a crown or bridge or veneer, or so many times the tooth itself might fracture. So you need to talk more about fracture lines and how to diagnose dental fractures. Once more, also you need to talk about not only dental fractures, but also so many times those prosthetic procedures are done over endodontically treated teeth. Endodontically treated teeth, they fail in terms of endo. So also you need to talk about the endodontic failure, how to describe and how to diagnose if there was an endodontic failure beneath our restoration. And then when is the decision to go through the restoration to treat the tooth, or it's an apexification case? So apexification usually comes when the restorative work or the prosthodontic work is very good and the endodontic failure needs an apical seal. So why not gain the apical seal from the apicectomy rather than going towards removing a beautifully accomplished bridge or restoration? Especially if it was expensive. So the apexification might be the source of the seal we get to resolve the endodontic failure. So you need to talk about endodontic failures beneath prosthodontic procedures. Also, you need to talk about periodontal failures. So, for example, when we lose that when the restorations fail because of the periodontal infection around them. And this is also relevant to implants when we're talking about peri-implantitis. When do we consider this fixture is failing in terms of bone integration or because of the periodontal case? You talked about the periodontal when we talked about how to maintain the protocols for maintaining implants and implant related prostheses. But you haven't talked about how to diagnose more if peri-implantitis is happening and how do we treat this complication before it goes beyond the repairable stage when we need to remove the implant. So the decision to remove an implant or not, the decision to leave it in place, what are the criteria, what are the types of mobility that happen to the implant, what are the types of probing depths that we are concerned about, when do we need to intervene, like just open a flap and just clean around, for example, we need to go for periodontal, extensive periodontal or medicated periodontal treatments and so on. So you need to talk a bit about the peri-implantitis or periodontal failures even in dentate patients. One point we need to talk about as well is when do we diagnose unilateral failure, meaning that especially when we have fixed prostheses or when we have bridges, for example, if one of the teeth fail and the other is still functioning, how do we deal with those types of fracture or let's say those types of failures? So it's only part of the fixed prosthesis that failed. It's one implant that failed, for example. It's one tooth that failed, as if it was a bridge and one of the abutments failed. So if we have the failure is localized, it's not generalized, how do we deal with this? Okay. When we talk about also cuspal fracture, for example, in the dental when it's not only crack lines that happen, but also sometimes it's part of the tooth fractures. So you talked about the chipping of the porcelain in the ceramic, but you haven't talked about the loss of a cusp, for example, or loss of dental structures. Sometimes those fracture are fracture lines after the fracture has happened. The fracture point is above the gingiva or subgingival or even subalveolar, for example. So we need to classify those types of fractures that happen to the cusps. And these are the most types of fractures that happen for inlays, for example, where we have cuspal fracture or endodontically treated teeth. They also have around endocrowns. So we might have those. And how to prevent them you're going to go dive more into when we need cuspal coverage and when do we not need cuspal coverage to protect the remaining tooth structure. So all of these issues about complications, you haven't addressed them. I would wish for you to add more about these subjects. And I once more thank you very much for your presentation, and inshallah see you in the next presentation. Any question from your colleagues? Anyone who wants to ask anything or include anything in failures? By the way, I haven't talked about, I remember that just now I didn't write it down with the list. Also, how do you deal with post fractures? So in terms of post fractures, there are some types of when do I decide I need to remove this post, and when do I decide to leave it in? And if I'm going to remove it from inside the canal, what are the tools I'm going to use for the repair of a post, the dental post, especially if it was a fiber post? How do we go and treat that fiber post or retrieve it? Okay, so it's almost more about retrievals. Okay, so we want to dive more into those subjects. And thank you once more very much for your presentation. And I hope for you all the best. This was our final presentation in the course of current topics. And we hope to see you in your graduation ceremonies very soon. Thank you very much, doctors, and see you in our next sessions. Any question?
No, Doctor, everything is clear.
Yeah, okay. Thank you very much. And see you next time, inshallah.